I'm going to do just a really brief introduction. Greatly appreciate on a Wednesday afternoon, last day of SMFM for a full house. Greatly appreciate that. I'll do a quick introduction. My name is Dr. Mike Ruma. I'm a maternal fetal medicine specialist. I work in Albuquerque, New Mexico. I want to introduce my co-speaker here, Derek Joyce. I'll let him tell just a little quick intro.
Thank you, Mike. So Derek Joyce, I am in our scientific affairs department at Hologic. I've been there about 10 years. My background's more in molecular biology, but came over and support our FFM product in our perinatal division. So for the last 2 years, I've been trying to absorb everything I can in this space and loving the SMFM meeting and the people and context here.
All right. We're going to do kind of a combination. I'm going to talk for about 25, 30 minutes. I'm a rapid fire speaker, so I hope you can keep up. You've attended really a lot of scientific sessions, so I think you'll be able to do so. We're going to talk primarily about, I think, a topic that's pretty interesting and a hot one. If you went around and looked at any of the poster sessions, I think there's probably 30 different posters on timing of steroids, harms of steroid, potential issues related around antenatal corticosteroids. I want to talk to you a little teeny bit about history, a little bit about the timing, some controversy, some research, obviously, and then maybe at least personal perspective on how we might try to improve that. Number one part, 99% of my life is being a maternal fetal medicine specialist. I worked in Santa Fe, New Mexico yesterday. I saw 18 patients, did a CVS on a lady with a cystic hygroma, ran to the airport as fast as I could, flew here, got here at 1 in the morning. In my fun spare time, I also do a lot of outside work with a few collaborators, Hologic being one of them. CCSI is a company that makes digital NSTs, and then Philips makes ultrasound equipment. I grew up in Omaha, Nebraska, went to Notre Dame, if there's any ND football fans in here. Also went to University of North Carolina, Chapel Hill, where I became a Tar Heel basketball fan as well. I know I got a couple IU folks over here, so Dr. Haas, we'll talk about basketball later. And I've been in New Mexico for the last 16 years. New Mexico is an interesting place. Would invite you all to check it out if you have an interest and never have visited there. It's the 5th largest landmass in the country. We currently have a variety of offices. Last year we saw 8,400 individual pregnant patients. There's a lot of complicated pregnant people there if you have an interest in working with us. And just a little teeny bit as a kind of a unique perspective as an MFM, founded in 1987, a private independent medical practice. It's relatively rare these days, honestly. We currently have 5 doctors that work in the practice. We use an army of nurse practitioners to help reach patients, a lot of which we've incorporated into some specialty areas. MFM care, obviously, we do global care. We do not only outpatient, but we also do inpatient care at one specific facility. We do a lot of diabetes management, and I know there's interest at SMFM for that. And I'm very proud, this meeting particularly has been orchestrated solely around maternal mental health. This has been an eye-opener for our practice. If you're not doing mental health work for pregnant people, I'd greatly encourage you to think about doing that. We took a risk and hired a few psychiatric mental health nurse practitioners in 2021 at the end of the year. Saw about 100 patients within 2 months, filled up one nurse practitioner, hired another one. We saw 1,000 patients in the next year, and this past year we saw 2,000 individual patients for mental health care. Very, very interesting realm. New Mexico is a great place. Why would you want to come visit and when? October is the time, the first 2 weeks. We host the largest balloon fiesta in the world. This is the International Balloon Fiesta. Beautiful photo over the Rio Grande River. 600 to 800 balloonists come to Albuquerque. It's a unique place because we have altitude, rising mountains, a beautiful river. We create these nice little thermoclines that allow the balloons to fly. Very predictable flights. So great place to come for a balloon ride. All right. I might wander around a little bit, ask you guys some questions, and interact with you a little teeny bit, but I want to talk to you about a few topics. One, happy Valentine's Day. What a serious dedication on Valentine's Day. Hope you say you love, I love you to somebody today. We love this particular topic. I think antenatal corticosteroids, we have a tremendous amount of love for this particular topic. It's important always to reflect on the history. talk about some studies that have come out, some recommendations, and then I know we'll have some controversy. This particular medicine, some individuals, I think we would say probably is the maybe most effective therapy medication we have in perinatal medicine. It has undoubtedly affected the lives of innumerable infants. It's controversial and still has a significant amount of uncertainty around it today. As you know, RDS is the issue, one of the major ones. This medicine helps a lot of different other areas. RDS affects, half of babies born less than 28 weeks, a third under 32 weeks. If you like birth weights, up to almost 40% under 1,500 grams. Surfactant deficiency, lung maldevelopment, underdevelopment, immaturity, other organs contribute to this. If you're a resident or a fellow, this is, your classic board question, this beautiful little type 2 pneumocyte that produces surfactant. When we expose a mom, a pregnant person, to a steroid, their cortisol levels go up, we produce more surfactant, but we know physiologically that declines over time. I like history. Graham Liggins should be credited with the initial research on this particular topic. Pediatric publication, 1972, 52 years ago. Antepartum glucocorticoid treatment, prevention of respiratory distress, 282 moms randomized to essentially the exact same medication we use today. They found that if they repeated that dose, that was the study, and they wanted to see the clinical outcome was respiratory distress syndrome and reduction thereof. We're going to spend a lot of time talking about the optimal timing, and that's a controversial topic right now because we seemingly don't do a great job on timing steroids properly. You'll see there that little red arrow. The effect in Liggins' study was only seen when steroids were given 2 days prior to that delivery, and that kid actually was born within 7 days. RDS, 3.6% in the treatment group versus 33% in the placebo group. Profound risk reduction if a pregnant person got steroids prior to actually having a preterm infant. Liggins summarized his study saying that RDS occurred less often in treated babies versus placebo controls. And from the present results, Liggins said that he concluded there was sufficient evidence of beneficial effects to actually do more studies. And I'm pretty honored because we have one of those individuals, Dr. Greedy, who's actually done one of the 24 studies that replicated this particular Liggins trial. And the basic design of Liggins trial, this RCT, was repeated numerous times up until about 1994 when the NIH said, hey, we have enough trials on this topic, let's put it to purpose and actually use this medicine. Where are we 50 years later in this? Here's a document. You can see red, yellow, blue. There's a lot of edits to this particular document. This document in recent history has been changed about 5 or 6 different times. Why? Evolution of research, what we're all here at SMFM doing. ACOG, SMFM, this combined statement, they agree with Liggins' research. Antenatal corticosteroids prior to a preterm birth is one of the most important antenatal therapies to improve a newborn's outcome. For 24 weeks and 0 days to 33 and 6, if that preterm delivery is anticipated within a week, we should give steroids. Single course antenatal late preterm steroids. Cynthia Giamfi-Bannerman, our forthcoming president of SMFM. Antenatal late preterm steroid trial published in the New England Journal of Medicine. 34 and 0 to 36 and 6, we should offer a course of steroids. What about periviable, that 22 and 0 to 23 and 6? If delivery is anticipated, shared decision-making, the patient elects and desires that, outcomes are improved. You notice that there's something about 7 days. Everything. What is so darn important about the 7-day cutoff? Liggins, 1972, told us about this. Steroids affect and improve outcomes of respiratory distress. It helps decrease NICU admissions, NICU death, infection, bleeding in the brain, all these things, none of which you want for your baby. If I, as an MFM, have a patient who's in preterm labor, she breaks her bag of water, she has preeclampsia, she's 28 weeks, give her steroids, and then we don't deliver her in that 7-day time frame, we're not affecting significant benefit to that infant. if the kid, that baby, comes out 8, 9, 10 days, our RDS rates go up. 15, 18, 20 days later after that, two doses of steroids, 7-fold higher rates RDS. How do we do on this particular topic? This is data from Razaz out of Canada, 14-year study. The green line is good. Clinician made a decision. We administered a course of steroids. The patient actually delivered 2 to 7 days after administration. 23% receive optimal timing. Half of the patients in this study received it almost in the late preterm setting. We gave it preterm, and then they delivered much, much later. Numerous studies here at this meeting about this particular topic. We give a tremendous amount. We're very good at giving patients steroids. We're not good at timing it. Razaz says 20-ish%. Levin, British Journal, 2016, 40%. Varies based on the indication. There's several poster presentations in hypertensive disorders, in PPROM, and preeclampsia, preterm labor, how we're doing on this. Anybody seen this particular article from SMFM, 2022 special statement? I'll read the title. Quality Metrics for Optimal Timing of Antenatal Corticosteroids. This is 50 years later from Dr. Ligon's original study. SMFM agrees steroids are beneficial if administered within a 7-day window. They acknowledge the 2 studies we just reviewed briefly. Clinicians are influenced by lots of things. Patient in front of you, data, tests, ultrasound, governmental metrics. Anybody heard of the Joint Commission? They come to visit your hospitals. They tell you to put plexi pulses on your patients. Make sure you give antibiotics before the patient delivers by C-section. They measure our rates of how well we, quote, do things. The Joint Commission came up with a metric, this PCO3, years ago that said, does a patient who had any intervention or evaluation for preterm circumstances, did they get steroids? That was it. We were highly effective at giving steroids essentially to anyone who walked into our obstetric triage units. I've done it. I'm sure you've done it. Patients in preterm labor, she's not dilated at all. Maybe we did an ultrasound, it was normal. Maybe we did a lab test, it was negative. We still gave her steroids, just in case, right? Yes, at least one yes. So you've done it too. We're cautious, right? But we also want to do, you guys probably went to these quarterly meetings or maybe monthly meetings. We call them medical staff affairs meeting, where you have some person who does all your quality metrics for the hospital. And if you're not getting 100%, they want you to achieve 100%. Don't have 3rd-degree lacerations. Okay. Make sure you give steroids to every single person who walks in, because if they deliver preterm and you miss that person, you're not going to get a good assignment. We did really great on this, and we gave essentially 100% of pregnant patients that showed up with almost any indication in triage steroids. Joint Commission got rid of that. We don't need to do it anymore. We actually need to, and SMFM's asking us to, and hopefully in the future we're going to get some more information on this topic. They want us to improve upon this. Why? The metric incentivized me as a clinician to liberally give steroids. I just showed you 2 studies. It's not useful. If I give the steroids and she delivers 20 days later, there was not benefit to that patient, to that fetus. And interestingly, also, we're honored to have people in the room that have done research on this topic, particularly Dr. Haas and his group in Indiana. NICU admission, SGA, maybe neurocognitive outcomes. We're trying to give a medicine that should help the fetus, the unborn child, but actually maybe we're contributing to some bad outcomes. And I'd encourage you, if you type in steroid into that nice PDF abstract document, there is a lot of data just at this meeting. And if you went in PubMed, there's probably 100 articles in the last few years on this particular topic of concern. Here's a handful of them. 2019, neurodevelopmental disorders among term infants exposed to steroids. We're going to talk a teeny bit about that JAMA article. I can't pronounce her name, sorry, Rykoken. Mental and behavioral disorders in children that received maternal antenatal steroids. Vandermeer, 2022, AJOG, neurocognitive sequelae of steroids in a late preterm rabbit model. Austin, McKenzie, Haas et al. Long-term childhood outcomes for babies born at term who are exposed to antenatal steroids sometime in their pregnancy. This is the study from Finland. This is an interesting one that kind of started a lot of controversy in 2020. Unlike America, we don't have we have EMRs, but they don't talk. Moms and babies are not linked great, but in Europe, they really are linked well. Primary outcome on this one was if a mom was exposed to steroids sometime for any reason in her pregnancy, what actually happened to the baby? And they looked at the kids' EMR from birth to 9 years of age, 15,000 antenatal corticosteroid exposed kids. And interestingly, 45% of them delivered at term. 55% delivered preterm. So they're not really doing much better than the two studies. They're helping document that. This is what they found. If overall, the whole group, if that baby was exposed to in utero steroids, there was a significantly increased risk of mental and behavioral disorders in the entire cohort, 6 versus 12%. But interestingly, when you subdivide it between term and preterm deliveries, it seems that when we give steroids to a preterm patient and the baby actually delivers at term, there is a phenomenon present. If we give steroids to a preterm infant and the baby is delivered preterm, there does not appear to be that same outcome. They expanded this study from 0 to 9 to now 0 to 12, 2 years later, and they got more specific instead of just aggregating all the diagnoses together that were considered neurodevelopmental. This one they got more specific: speech and language, scholastic outcomes, psychological, pervasive developmental disorders, vision problems, things we don't want in a child per se. 5.6 versus 3% in the aggregate overall cohort. Significant increase if a mom is receiving steroid medication in utero and her child is born. There seems to be some potential concern about the outcome for that person. Again, in this one, confirmed to term-born children. Adjusted hazard ratio 2.2. Has anybody had a patient ask them about whether or not you should give them steroids and what the outcome is to their baby yet? This is slowly happening. The patients are reading this information. They're asking questions. I came in with contractions. I'm not contracting anymore. My workup, I'm not changing. Do I really need the steroid medication? I have my preeclampsia without severe features. Do I really need the steroids? I had a patient recently. She's a university graduate level librarian. Her husband's a statistical engineer. You've seen the movie Oppenheimer. That was invented in New Mexico in Los Alamos. Super incredibly smart astrophysicist husband. Tell me, doctor, about the statistical risk of neurocognitive outcomes for my child. I have a vasa previa present. We're going to admit her at 32 weeks, but I don't think I want to get it at 32 weeks. I'm going to wait the 2 days before my C-section. Reasonable, shared decision making. Indiana University, McKenzie, Haas et al. Patients who show up with threatened preterm labor, one of the most common things we evaluate in triage. If we give that person, that pregnant person, steroid medication, and she doesn't actually deliver preterm, what happens? 28% of the cohort, a third of them, so we're again very liberally administering steroids. The mean gestational age was 32 weeks. But interestingly, the mean delivery was term. We're not great predictors of what's going to happen. Indiana University found that we heightened the chance of that patient, that baby, going to the NICU and also being born small for gestational age. And I think we have historic data that shows that there may be some risk for SGA and growth restriction if we give too many steroids, but even this may have some association. So what did Dr. Haas and his group tell us? Well, we're having some concerns about preterm antenatal corticosteroid exposure. Maybe it heightens NICU and SGA. We need to, there is a theory now of at least some adverse impact of this medication. And we need better tools to predict delivery within 7 days. And I don't disagree with that. I think that that's very true, and I think we're all here How do we predict preeclampsia? When is it going to happen? What do we do to that patient? Patient with symptoms of preterm labor, profoundly short cervix. What do we do? How do we intervene? How do we protect that patient? SMFM goes a step forward in their document, and I really would encourage you to take a look at it because this is important and something that we're going to continue to see and hear more about. While better tools are needed, we probably can make some impact with just with what we have today. And we should maybe pause and actually think and reflect before we actually act and administer a medication. And so SMFM is encouraging us as clinicians to be thoughtful about this. Avoid administration of steroids in patients whose preterm birth risk is low. Patients with contractions. Pregnant patients love to contract, right? It's the bane of our existence. They all contract. We look with ultrasound. We do lab testing. SMFM would provide a paragraph line that says patients with uterine contractions preterm and a negative fetal fibronectin test, which has a high NPV, then maybe that person we should pause and not administer steroids to. Asymptomatic short cervix. I'll show you some data from our colleague, Dr. Gianfi Bannerman, about that topic. Maybe that alone is not sufficient for us. So you're all here today. I love talking to a group like this because we want to inspire new research, right? We want to help you. We want to work together to make this better for all of our patients. The society wants facilities, groups to develop pilot improvement projects on quality. How do we improve optimal timing of steroids, which inherently will help reduce this risk of potential harm to a neonate on all fronts? We can talk to patients. We can examine patients. We can do a cervical length. I love ultrasound. I do so many of them in my office. 8,400 individual pregnant patients in New Mexico last year, 130,000 ultrasounds. I mean, it's busy, right? We do a lot of ultrasound. We do lab tests as well. What do you guys see? How do you guys see this done? Is it done the same in California? Is it done the same in New Mexico? Is it done the same in Tennessee, Indiana, Florida? Is there a standard of care to it? I'll give you one example. This is from Mayo Clinic. They follow these algorithms. I kind of purposely make this small because I don't want you to stare at too much. Because honestly, talking about this, none of us do this the same. I've given 100 lectures on this topic. Some people do a cervical exam. Some people have nurse practitioners doing it. Some people have midwives do it. Some people do an ultrasound. Some people don't check them twice. I don't know how you see that the cervix is changing without checking the patient twice. And so there's algorithms and have shown success if we follow these things that we can actually predict things better. I'll share with you a little bit that cervical exams are not perfect. If she's 0 to 1 centimeter dilated, 84% of them are going to deliver after a week. There is some data today from a poster that shows that cervical dilation may be the most important predictor. Even if she's 2 centimeters, 70% of those patients deliver a week later. 1997, Dr. Greedy can tell us so many stories about this, but fetal fibronectin came out and was first promoted as a negative predictive value test. Just like lots of different tests, cell-free, DNA, NIPT, the benefit is in the negative predictive value. The patient is reassured. Ideally, the clinician is reassured, and we actually follow the test result. It's an FDA-approved test for 2 indications, symptomatic and asymptomatic patients. But in symptomatic patients that come in with contractions preterm up to 34 weeks and 6 days, if she has a negative fetal fibronectin, there is a 99% chance she's not going to deliver. Are we giving those patients steroids? And could there potentially be maybe some outcomes where we don't like if we actually do act and don't evaluate patients properly? What do you guys see happening today? If you have a patient that comes in, I'll give you, maybe ideal world, if we have a preterm labor patient, best thing, we do a physical exam to them, we ultrasound their cervix, and maybe we do a lab test. Here's a study showing us what that looks like. This is Wilms from the Netherlands. They did a massive study. They only did ultrasound in the Netherlands. to evaluate preterm labor. What they found was that if they incorporated another test, the fetal fibronectin, they actually had better prediction. But they also tracked how they treated those patients. Cervical length over 30. Board question, is that normal? I think most MFMs would consider that a normal test. 30%, 23% of them got steroid dosing. How about in the Netherlands? What we in the United States, we'd call this an equivocal or indeterminate cervical length, 10 to 30 millimeters. And that patient, she has a negative diagnostic lab test with an NPV of 99%. And interestingly, 65% of those patients they gave steroids to. Maybe the groups we should consider are groups 2 and 1. I mean, a cervical length that's indeterminate with a positive fibronectin, 18% of them deliver preterm. Really short cervix, 65% preterm within 7 days, and all of them got steroids. But those top two groups, group 3 and 4, we probably should not give steroids, right? That would be an easy thing to intervene to help right now. And maybe ideally, this group, we could come up with a project. We love cervical lengths, right? I like talking to nursing staff, residents, fellows. How long are you supposed to look at this cervical length? 3 to 5 minutes. You guys all know. You're all board examiners. If I talk around the country, probably 100 different talks, 3 pictures, 3 seconds, as fast as humanly possible, right? Nobody wants to do it. It's 2 in the morning. Maybe it's not even available. But if you do wait 3 to 5 minutes, what comes every few minutes? Right. And on minute 3, this is what it looks like, which that's the shortest, best cervical length. That's way different. It's got U-shaped funnel. There's debris, and it's 5 millimeters. Way different. We need to be leaders in how to do this particular test as well. But we need to incorporate and trust the lab tests. So this is a study by Gomez in 2005, cutoffs of cervical length at 30 and less than 15. Look at the NPV of this test. So I'm sorry, the laser pointer is just over here. Cervical length, yes, is short, negative fibronectin. You come over here, and the delivery within 7 days is 11%. Short cervix with a negative fibronectin, would not recommend giving steroid dosing to that person. I think 90% of them are not going to deliver in 7 days. And then even if they're extraordinarily short, here's really less than 15, really negative FFN. You come over here, still 65% of those patients aren't going to deliver. You guys ever have patients get admitted because one of your colleagues did an ultrasound and the cervical length was just like that picture I showed you? It was like 8 millimeters. Admitted, pregnant person, asymptomatic, or maybe she came in contracting. We did an evaluation. Her cervical length was so short that we kept her. This is an interesting study as well by Dr. Bannerman, that if the patient ceases contracting and is actually asymptomatic and has a short cervix, if that fibronectin test is negative, look over here, under 10 millimeters, this is really short cervical length. Delivery less than 14 days, none of these patients delivered. Former president of SMFM, Sean Blackwell, looked at insurance database, 5 states, large data review. How frequently are we doing these tests? What are we actually doing to pregnant people around the country? You guys think are we using all these great tools? We're using diagnostic information. We're doing ultrasound on every one of them. 23,000 pregnant patients in an insurance database. We discharged 3/4 of them home quickly. 1/4 of them got admitted. They were probably 6 centimeters dilated, but those patients we discharged home are the interesting ones. Most of them, 80%, are going to deliver much later, but 1/5 of them are going to deliver in a short period of time. And in this particular cohort, 80% of them have no ultrasound nor a diagnostic lab test that's available on the market and widely available. Ideal management maybe would be both, and only 1% of American pregnant people get that. And I would just ask you to reflect on what you do in your own institutions. I know in mine, it's pandemonium depending on who's on call and what the workup is, but could we do better? And is there a need to do better? Clearly there is a need for this. We have concern about the very medicine for 50 years we've been liberally giving. There's a tremendous amount of study, but we can improve on this today by simply listening to some of the approaches and tools that we have today. I'm going to ask you guys to, as I do, and I'm not an expert at this, I learn as I go as well, we have to keep reading the literature. We have to be thoughtful in the way we actually evaluate patients. There's an unpublished poster from American College of OB/GYN, a large institution, had 34 sites in northeastern US. They implemented a protocol for preterm labor that compared pre and post outcomes. They improved just doing a cervical examination, just telling if a woman that comes in with contractions, if she actually is dilated, they increased the second cervical examination by 90%. We're not even physically examining the patients, let alone doing all the diagnostic stuff. We need to trust the results. There is a lot of literature on this topic. Fetal fibronectin, you plug that into a keyword in PubMed, probably 550 articles. Ultrasound, 1,000 plus. Steroid potential harms in the last 5 years, about 100. ACOG wants us to do better, SMFM wants us to do better, they want us to make checklists, they want us to improve, and I think we have a tremendous amount of data on this. Antenatal steroids, for sure, one of the most important therapeutics in our realm of perinatal care. We're going to have a tremendous amount of research continued on this topic. And I hope that this group and companies and technological advancements, AI, who knows what the next goal is that's going to fix this particular scenario, that we actually can improve this metric that SMFM has asked us to do. We need to spend some time on this optimal timing. Love Atul Gawande. Anybody read this book? Checklist Manifesto? Have you ever had a chance to meet him? Amazing. I almost tackled him at the ACOG meeting when he spoke because reading this book, if you've never read this as a clinician, physician, nurse, doctor, medical student, really changed the way I look at patients, the way we do work and take care of human beings. We're obsessed. We want to have the best components, the best drugs, the best devices, the best specialists, the best maternal fetal medicine specialists. But are we actually the best? Are we doing what should be done to put all these pieces together and make it fit together well? Really, really great and enjoyable speaker. If you have not read it, I make no money selling Checklist Manifesto, How to Get Things Right. It's an excellent book. It's an easy, plain read. I'm going to pause here, and I would love to take some questions, and then I want to turn it over to Derek, who wants to share a little bit of the research that Hologic has been doing in the last several years, and see if there are any ideas or thoughts that you guys may have on where we should go in the future. Yes, ma'am. Yes. I'll blame that on a guy named Bob Bonebrake that Dr. Greedy trained at UCI. And preterm labor, are we good at predicting when the baby comes out? We all want the positive predictive value, right? I want that to be 100%. But we don't have it. But the test is useful for its NPV, and that's really how it got its FDA approval. I also, frankly, as an MFM, frequently the patient's been evaluated by a midwife, a family practice doctor, an OB. Maybe they've been there a few days and they don't know what's going on and they're contracting and it comes and goes, and oxytocin at 11 p.m. to 3 in the morning is frequent, and they always have contractions on the tokometer. That objective test is extremely helpful in counseling for me. In a perfect world, yes. I think what I've seen around the country is after 5 p.m., ultrasound is tricky. If you're working in an academic environment, I think the residents, fellows, 100% should be utilizing the combination of the two and looking at the studies out there that would point to that. Van Baren from the Netherlands would be one that dramatically shows there's a better prediction if you put them together. Yes, sir. Yeah. Well, from a negative perspective, I think you can use it completely by itself. And so if you don't have ultrasound availability, I do not think that you should throw your hands up and disappear. The laboratory test is highly impactful when it's negative. And the answer on this particular genre of steroids would be do not give steroids, in my personal opinion and medical opinion, and that's what I tell the patient in front of me. In the positive setting, patient with contractions, prior preterm birth, cervical lengths 5 millimeters, and oh yeah, that fetal fibronectin's positive. Now that PPV is rising dramatically. Andrew Shannon, in Europe, they use quantitative fibronectin, but at cutoffs of the 50 nanograms for fibronectin in the United States, when it's above that, we're approaching with a short cervix maybe 65–75% chance that that baby's going to deliver within a week. That would be the person personally that I'm trying to narrow the steroid dosing to. Yes, ma'am. Yeah, in the United States, not currently. Internationally, quantitative fibronectin, I'm not familiar with. Yes, sir. Yes, sir.
Shortening or under pressure, in distant time, we put in this patient is at risk of impending delivery. Most of these cases, patients progress several weeks before gestation. So this is something that so far has not been established role in our clinical practice, the dynamic assessment of the soul. The second question, because you have mentioned the circumstances of the patient that they step in with contraction, but I think that one of the tools that maybe now is under investigation in order to reduce the number of unnecessary administration of steroids may be the use of androgenic markers in patients with hypertensive disorder of pregnancy or other conditions that usually are candidate to steroids. So I want your opinion on that.
Yeah, I think we're going to learn a lot about that. I think patient breaks her bag of water, PPROM, that setting, 80% of patients going to deliver within 2 weeks. That person needs steroids. Patient with acute massive abruption needs steroids. A patient with severe preeclampsia that has abnormal labs and we think expectant management. These tests are not available immediately today in the United States. If somebody says there's a delivery modality, rapid fire, I definitely would be interested in that. Yes, ma'am. The lab test?
Sure.
There is a FDA indication for asymptomatic use, not frequently used in the United States, to be honest. I would follow our ACOG SMFM guidelines to put a history indicated, ultrasound indicated, or physical exam indicated. I don't think we have sufficient information societally to say do something or don't do something based on that lab test in that setting.
Okay, we are talking about mostly fibronectin, but I would like to ask you something about the corticosteroids and fetal restriction.
Yep.
Because we looked some of the data from the truffle group,
Yep.
and there were no differences in those that got or didn't get the steroids, because there's the evidence that the stress of the fetus is already enough to, maturate, at least in late preterm growth restricted fetuses.
Yeah.
So any comment on that?
I mean, there's a study, and I'm blanking, I don't know who did this one, but there's a poster here at this meeting that would argue against that. Small population, retrospective, truffle, much larger study. I think that we need to collaborate to figure out that answer. Repetitive dose steroids for certain in the 90s, we did that in the United States, Australia, causes microcephaly, circumference problems, which probably points towards the EFW lagging. So maybe it is not a pure effect. If Dr. Haas was still hiding in the back, I'd love to have quizzed him on that one. But yeah, I don't think that answer is fully developed yet. I'll turn it over to Dr. Joyce.
And yeah, appreciate that. And that's, I mean, a lot of these questions are great and exactly where I want to, do you have the clicker?
You may have the clicker.
Where I want to introduce myself to all of you and really open up to the research that we need and how Hologic can partner with you in that. So I'll give you a kind of brief introduction. So like I said, I've been with Hologic 10 years. Got my undergrad at Berkeley, where I had the unique experience to play football at Cal as well. So now they're part of the Atlantic Coast. We can maybe see more, all Atlantic Coast Conference, see them all across the country here. Came down to UCSD, where I did my PhD work in molecular biology, did my research at the Salk Institute, and then from then got into molecular diagnostics, mostly at Hologic. So Hologic invests in research in many different ways. One of which through unrestricted grants, including to the SMFM. I'm not sure if anybody saw the Impact Award that went out for applications last fall and recently awarded. Investigator-initiated studies. So people like you have an idea, want to be able to come and partner with Hologic, especially if you want to do something working with FFN, because that's one of the main things that I'm covering there. And whether that's looking for supplies, maybe funding, or even just getting some more partnership and information and data to help along with that, I can definitely be that liaison for you there. There's also Hologic-initiated studies. So we're trying to fill a gap in the known data or knowledge that's out there, and we reach out and try to partner with appropriate labs or appropriate academic institutions to be able to do that type of research. In addition, pushing the boundaries of what we can do and know we already have capabilities for the assays on hand. And personally, my current interest in this space, I'm relatively new to the maternal fetal medicine space in about the last 2 years. But one of the questions that came up a lot, like combining FFN with other tools, with patient history, to be able to get and better predict preterm birth. Or are there other biomarkers or types of things that we should also be covering? Another part of my job, we work in infectious disease diagnostics. And I'm looking on how that crosses over, again, into the pregnant women and into neonates, and how maybe we can improve that or where things are going for guidelines and improvement there. So on that note, this is where a lot of my kind of background and history was in that infectious disease molecular diagnostic space. So we have everything from STIs, vaginitis, our HIV and viral and hepatitis viral load assays, respiratory, you kind of name it, all the ones on the right currently in development. And I've seen a lot of posters and talks and things as well, incorporating those and its importance in the healthcare space here. As I mentioned, we probably supported the foundation for SMFM, and they had the Impact Preterm Birth Disparities Award, and that has been awarded to Saren Wheeler from Duke, and specifically looking at improving rates of preterm birth in the non-Hispanic Black population, targeting the time after an already previous spontaneous preterm birth, and trying to intervene and get into place, hopefully, things that can help reduce that rate for their next pregnancy. Additionally, we have papers that come out. A recent meta-analysis with Dr. Ruma here came out last November, December in journal, and this was specifically looking at other parts of the research. So this is looking at quantitative FFN available outside of the US, primarily Europe and Australia when available. And general consensus here is increasing, and this is looking in the asymptomatic population. Higher quant values give you a higher risk for preterm birth. one of the things that we had mentioned is being able to combine different tools together. So this is the Quip app, available from Dr. Shannon from the UK, where they take in patient history, patient characteristics, your BMI, you also add in your cervical length, your FFN, and it'll spit out percentages of chance of going into preterm birth if in the next 7 days, 14 days. I would love to be able to work with people here in order to, what's available here in the US? What can we put together to create something along this line to be more comprehensive, to be more universal and available across the country to be able to better predict preterm birth. Some of the other things, like I said, kind of pushing the boundaries. So these are a couple of studies that one was from Dr. Novak, looking at using quant FFN to predict prolonged induction of labor. So this is much later. This is not looking at people at threatened preterm birth, but just trying to help predict prolonged induction, as well as another study from Dr. Little from the Brigham and Women's Hospital, looking at, again, quant for prediction of spontaneous labor after 39 weeks. These go outside of our, it's quant, so not available here in the US and outside of our labeling, but we're always looking to see where is the next utilization potentially going to come from. Also been in a big partnership with Kaiser in Southern California. They did a big 10-year retrospective study looking through all of the births there, including over 430,000 births, 100,000 preterm labor visits, and 35,000 preterm births from 2009 to 2020. So you can imagine just the wealth of data in that data set. You can see how these women were screened. They have a very comprehensive history, so you can do all the adjusted ratios based off of the different confounders there, and also look in different ethnicities and different backgrounds over time, like how these rates are changing and how that affects them too. You may have seen some of the work at various conferences here. These are some of the different posters that came in looking at different aspects of that study. And there are going to be 2 of them coming up at the SRI conference as well. So if anybody is planning on going there in Vancouver in March, you can keep an eye out for the posters. One for prediction of preterm birth using FFN and ultrasound together, as well as association between FFN tests and infant outcomes. So not only were they looking at what was done, like when they were born, they also looked at the outcomes from that as well. And then, so the next question, what's next? What's on the horizon? And that's why I'm here, and really why I wanted to introduce myself to everybody in this room, because I need to be able to talk to me. You need to come to me. Please write down email address. I'll have business cards available as well. But it's very important for me to understand where you think, the knowledge gaps are needed, and if you have any ideas about how to work together to move these things forward. And yeah, thank you all for attending here. I know we all, probably many of us have a flight to catch, but would gladly take any thoughts or additional questions, either for Mike or myself. All right, I think we're set. Yeah, if you have any just personal ones, feel free to come to me directly. It would have been better if you knew at the beginning, because I'm easy to spot in a crowd, but yeah, please feel free to reach out.
Thank you very much for coming, y'all.
Thank you all.